Okay, on this assignment, responding to a chest pain call. Not a lot of pre-arrival instructions on this assignment, just that it's a female, approximately 50 years old or so, having chest pain, unknown any kind of past medical history or any treatment that's been given so far. We do know that it is in a school, and they've requested no lights and sirens upon arrival. And normally you might say to yourself, well, if they don't want lights and sirens upon arrival, how much of an actual emergency could it be? But if you think about it, in this case, since it is a school, they probably don't want lights and sirens because of they don't want to disrupt the classes that might be going on. And it's a elementary school, so there's probably a lot of young children who might get excited if they start hearing lights and sirens between the ambulance, fire, or police that are showing up to the scene. We do know, again, it is in the nurse's office in the school, so there might be some treatment going on before we get there. But what do you want to think about on this type of job? It is a chest pain, so you got to start thinking about your nitroglycerin, your aspirin, oxygen, IVs, EKGs, 12 leads, all that. Start thinking about, when you go into an assignment like this, what you can do under standing orders, what you can do under medical control options, and the steps you have to do them in. Some protocols want you to do the EKG before the IV. They want you to maybe give aspirin right away, get some type of medication on board. They might want you to go ahead and start off with your oxygen. Every protocol is different. Many are very similar, so you have to, of course, follow your local guidelines and your local protocols. You never know what it's going to be when you get there. Without a lot of pre-arrival information, it's hard to make judgments about what you might find, what you might not find. Of course, as an EMS provider, you have to kind of be prepared for whatever might present itself. This could be an actual true heart attack. It might be an anxiety attack. It might be, maybe she's just having some abdominal pain. We're not going to know until we get there. So I'm going to keep thinking about what I can do for this patient when I arrive, and what my steps are going to be, and how I'm going to approach this patient, and start getting some basic information that's going to help me to treat and transport this patient. So we're going to go ahead. We're going to be there in a couple of minutes, and I'm going to give you an update when we're done with the call of what we found and what we actually wound up doing. Okay, so done with that transport on that chest pain. It turns out the patient was having some substernal chest discomfort for about 3 days, actually, and she was actually at the emergency department the night before, and they released her without any type of definitive diagnosis, and just to follow with her doctor. EKG wasn't really showing anything. Her vital signs were stable. They weren't elevated or low or anything like that. But she was having consistent substernal chest pain, no shortness of breath, and everything else seemed to be pretty much unremarkable. The nurse on the scene prior to we got there gave her 325 milligrams of adult aspirin to chew, so I imagine that must have been pretty tasty. But what we wound up doing is we did the 12 lead on her. We gave her standard BLS care, oxygen, monitored her vital signs. I started an intravenous on her, and I did give her 1 nitro spray. Her pain was a 4 on 10, she described it as. After the nitro spray, it was like a 1 on 10. No change in her vital signs after the nitro. So whether or not she's having a true cardiac event or not, it's not for me to say as a provider. She met enough of the guidelines and signs and symptoms, in my opinion, to go ahead and treat her as if she was having some type of an angina attack, or maybe an MI. It could have just been angina. She has been under a lot of stress lately, and she is a smoker, but no other significant history going on. So it was a pretty straightforward case, and wasn't too much we could do. Couldn't get too invasive with her, but we did treat according to the protocols and the way she was presenting. We were comfortable enough to go ahead and treat her under an angina chest pain protocol and transport her to the hospital. So I hope you got some tips on this. And again, I think the takeaway for this type of a call is to just think about what you're going to be doing when you get there, and maybe just try to stay ahead of the curve when you respond to calls, and give yourself a chance to get the mindset of the type of call you might be getting to and what you might be able to treat for or not treat for. So this is Jim Hoffman for the EMS Professional at ems-safety.com, and as always, stay safe.